Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our conversation with Cancer Expert series, we have one of the leading leukemia experts in the United States, Dr. Daniel Pollyea, who is chief of the division of hematology at University of Colorado and a renowned leukemia researcher. So, welcome, Dan.
Well, thanks, Ravi, for having me. And as we were just talking about before, it's so exciting to connect with you, given all the work that you and I did years ago in this field. And you're definitely somebody I've always, continued to really look up to. So really appreciate you having me for this.
Thank you for those kind words. So what we're going to talk about is about FLT3 inhibitors. So just let's get started. First for the audience, how common is FLT3 mutation?
Yeah, FLT3 is amongst the most commonly mutated genes in AML. I mean, upwards of a third of patients will have a FLT3 mutation that usually skews a bit younger, and is associated with more proliferative disease that has more aggressive features. But it is one of the most common genes mutated in AML.
So is it a mutation that occurs very early in the evolution? Is it a late mutation? How do you describe it?
Yeah, we typically think of the FLT3 ITD, so it's important to remember there's two main types of FLT3 mutations. There's the FLT3 ITD, which we're mostly talking about here, has a negative prognostic significance historically, causes proliferative disease. And then there's another mutation that can occur in the tyrosine kinase domain of the gene. So when we're talking about the ITD FLT3 mutation, we typically think that that's a late mutation. So that's something that occurs later on in the development of the disease. And it's also can be kind of what we say promiscuous. It can be a mutation that is present, let's say, at diagnosis or not present at diagnosis, but comes on at relapse. So it's an important one to always be looking for, even if it wasn't present at the beginning.
And you sort of hinted at this about the two different kinds of abnormalities we can find in the FLT3 receptor. Could you just give us an idea of how common and what the implications may be?
Yeah, so the more common is the FLT3 ITD, and that can occur in this juxtamembrane domain. And there's this insertion that can be upwards of many dozens of additional base pairs, and that accounts for the majority of the